Hello, everyone. This is Pedro Ramirez. I'm the editor-in-chief of the International Journal of Gynecological Cancer, and I want to welcome you to today's Journal Club. Of course, I want to also thank the ESGO and IJGC for their support in our Journal Club. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussion, and the recording will be made publicly available. Participants with your cameras turned on may appear in the video recording, so please keep that in mind. We ask that everyone please keep your microphones muted so everyone can hear the presentation and we don't have any interruptions. And if you're having any difficulties or questions, please send a message in the chat, and we'll get our technical support to assist. We definitely want to encourage lots of questions, and hopefully we'll have time for discussion as well. Obviously today it's a special Journal Club. We have Professor David Cibula, a good friend and colleague, and it's always a great opportunity to learn about cervical cancer. Obviously, he has contributed tremendous amounts to cervical cancer, and he's the author, one of the authors, but lead author of the ESGO-ESTRO ESP guidelines for the management of patients with cervical cancer, the 2023 update. So I'm very, very, very pleased to welcome Dr. David Cibula to join us. And David, once again, thank you for being with us today and sharing your insight into this article and the guidelines. As we mentioned prior to going live on the podcast and the Journal Club, that these guidelines have been anticipated, and these guidelines have been also obviously very much awaited and with some level of controversy around them, and we're hopefully going to discuss those as well. So David, I don't want to take any further of your time. Thank you so much once again for being with us. And I think you're going to give us a brief summary of the guidelines, and then we'll get to some of those questions.
Pedro, thank you very much. What I would like to say first is to really thank you for this opportunity to present the guidelines, and also for the selection of the paper as the lead article of the journal. It's really an honor for us, on behalf, of course, of the whole group, because it's the international working group which is behind it. If I have a time to summarize a little bit, although it's not easy to summarize the guidelines, there are a few highlights which I think is worth of mentioning. First of all, it's truly multidisciplinary work, because not only were 3 societies behind it, there were experts from medical oncology, radiation oncology, pathology, palliative care. So it's truly multidisciplinary work. Second one, it follows the ESGO guidelines for development of the guidelines. And there is one point which is important, and this is external review. So in the middle of the development, we sent the raw material into really hundreds of colleagues around the world. We receive hundreds and hundreds of comments, and then the group discussed everything and try to implement it into the final version. So there is this second round of, let's say, opposition or discussion already implemented. Then what I also would like to say is that besides the recommendations, there are also algorithms which are published together in the paper, which used to be quite popular, because it serves very well for the fast orientation, and it's case oriented. So it's easy to find the recommendation for your case. And these algorithms are later translated and used for the app. So there is the ESGO app, which is available free for Android and for Apple. And I hope that this has already been updated, and if not, it will be soon.
Well, David, thank you so much again. I mean, as you mentioned, we can spend hours discussing the guidelines. And, for those of you who have listened to the podcast, I know that we covered in some of the most relevant points and potentially some of the more controversial points. And we can certainly have expanded to that. I also want to say, I think that this might be the highest attendance that I recall in any of our journal clubs. We're right now at 123 people who have joined us from all over the world. So we're extremely happy and proud to have everyone. So again, submit your questions as well. We're going to start right into the questions from the fellows. And the first one is Giulio Bonaldo from Italy. And Giulio, why don't you go ahead and ask your first question?
Yes, of course. Thank you, Pedro, and thank you, Dr. Cibola. Well, when new guidelines are published, there is great curiosity about changes in general in clinical practice. So which is, in your opinion, the biggest change in the treatment of cervical cancer that these new guidelines have brought? Thank you.
Giulio, do you ask me about the surgical approach?
Well, in general.
Yeah, of course. I'm kidding. There are some changes actually in each and every chapter. So there is a change towards less radical treatment in fertility sparing. There is immunotherapy in metastatic and recurrent disease. There is indeed a change of the recommendation for the standard surgical approach for radical parametrectomy from minimally invasive, which used to be recommended in the previous version, to open surgery for obvious reasons, Pedro. And but I was, if I were to specify what for me is one highlight. For me, it was important to realize that we did not make any fundamental change. Those after, again, everything was discussed again, because once you have a new working group, you start from scratch. So it was not given. But after many days of discussions and exchanges of data and strong opinions, at the end, the changes are rather small. So this gives me a sort of feeling that our previous version was not completely wrong, that we made just some minor changes. Thank you.
Well, great. And David, I'll follow up with that with one, I think probably the least controversial, the use of minimally invasive surgery in tumors less than 2 centimeters. So I wanted to, certainly I think that this was also something that when we heard you presented in the original presentation at the ESGO meeting, came as a bit of a surprise. And of course, obviously, now we are about to hear the results of the SHAPE trial that are going to be presented on June 2nd in Chicago, for those of you who are going to be there at the ASCO meeting. But I think, certainly the question has come up by many with regards to where do we get the evidence to suggest that less than 2 centimeters cervical cancer can be treated with minimally invasive surgery?
Yeah, each guidelines is a consensual work. So of course you have publications, you have evidence, and then you have experts, and the aim of this heterogeneous group to find a consensus, because that's the main goal of it. This topic has been really thoroughly discussed during the development, and what is included in the guidelines, it's simply the formulations which finally we agree on. It's not that simple. If you read the guidelines really carefully, it's not that we recommend open surgery for tumors above 2 and minimally invasive. No. It said that the standard approach is open surgery, and that there is an option for using minimally invasive for lymph node staging, which from what I'm hearing around the world, it's quite often current practice that they do sentinel lymph nodes by laparoscopy, and if frozen is negative, they open up the abdomen and do radical from open approach, and then it says. And then it says that there is an option for using minimally invasive under many conditions, and it's, you know, if they follow ASGO quality indicators, meaning that you have the volume, if they have, you know, practice, if they have audit, you know, their data, and specifically in tumors after colonization. So, you know, to expect that in tumors less than 2 centimeters after colonization, so there is, in fact, in majority of cases, no tumors at all in, you know, in the time of hysterectomy, that the approach can significantly change the prognosis is difficult.
Yeah.
One argument, if I may, you know, I had a call after the LAC trial from one of the guys who is, you know, one of the leading person in minimally invasive in surgical cancer, and he said, David, I need to visit you and learn how to do radical surgery by open surgery. And I said, please don't do this, because you've done it for 30 years, you know, very safely. So it would not be the best idea for you to switch now to open surgery.
Yeah. So David, I want to jump into some of the questions that are coming in the chat. This one is from Sarika Gupta, and she asks, can you please elaborate as to why using the TNM classification as a better prognostic tool than FIGO? Do you mean to suggest that FIGO staging needs improvements, or surgeons should not use FIGO? Please give us your insight on this.
Yeah, this is exactly our message. That TNM classification, especially in cervical cancer, you know, tells us more than FIGO classification. And to separate T from N is very important, and it's very important for the management. This is why, and we, you know, again, a long discussion behind it. There were, of course, strong supporters of the FIGO classification because it's used worldwide, you know, it's used in the reports, it's used in majority of publications. So the guideline says that optimally TNM plus FIGO should be used, but for our purposes and for the purposes of the guidelines, it was really much easier and better and more precise to use TNM. So to separate N situation from the T situation. Very well.
Another question now that comes in, and I'm sorry I'm going to be changing subjects, but there's a lot of obviously interest in the new guidelines, is regarding the lymph nodes. So this comes from Fabio Martinelli, and I think Fabio wants to take advantage of the fact that we're highlighting his questions. So he actually put 3 questions. So, but he was asking more so about frozen section of sentinel lymph nodes. Should that be done? Considering the Centix data, why then perform lymphadenectomies? In what cases should we perform lymphadenectomies? And also, one third question is regarding aortic lymph nodes. Do those have a place at all in the evaluation of patients with cervical cancer treatment?
Yeah. Well, frozen section from the data which are available, you know, of course you can look at it like it's not reliable because it can detect only 50% of positive lymph nodes. But, you know, think about it, you know, for the second time, it's the other way around. It's frozen section allows us to detect 50% of patients with positive lymph nodes. And it's a great opportunity. Of course, only if you will act accordingly. So if you will really stop the surgery and refer the patient for chemoradiation. But in general, if you and I or agree on the general principle that the management of early stages should aim at really trying to minimize patients who finally receive the combination of radical surgery followed by adjuvant treatment. If you agree with that, if not, then you don't need this information, of course. But if yes, we have two strategies. First is to use reliable imaging before the surgery to know about really bulky lymph nodes and locally extended disease, because using either MRI or expert ultrasound is very reliable in that. And then you have the second step, and the second step is intraoperative assessment of lymph nodes. And without sentinel lymph nodes, it's very difficult to do that, because you don't know which lymph nodes to send for frozen section, and try to send 20 lymph nodes for frozen section. It's impossible. So one of the advantages of sentinel lymph nodes is that you can detect really 2-3 lymph nodes and send them for frozen section, and tell your pathologist, those are the most important lymph nodes in the pelvis. So they can do frozen and they can detect. In the Centix, we already have final data. Frozen was mandatory. And out of 650 patients, we detected by frozen section 50 patients with intraoperative positive lymph nodes. So these patients were spared from a combined treatment because the surgery was stopped and patients were referred for chemoradiation.
And well, certainly, I want to also give Fabio the opportunity to rebuttal, or are you absolutely completely satisfied with that answer?
Yeah, hi everyone. Of course, I'm a fan of Sentinel of this section, of course, and that's why looking for the 50% who can be spared any additional treatment, of course, is a good point. I think that the question may be regarding the pathology available in each center. That needs to be of high quality, of course, otherwise we can miss also positive notes in some case. And of course, the other one, why if we rely so much on Sentinel, why to do pelvic anatomy after the Sentinel?
Yeah, well, there is another point, Fabio, which is also important to say, and it is that this next 50%, which are detected by ultrastaging, are really detected by ultrastaging. So if we don't do sentinels and if we don't do ultrastaging, these patients would be undetected. They would be among lymph node negative patients. So it's not like, using sentinel. No, sentinel lymph nodes, the biggest advantage of sentinel lymph nodes is much better accuracy of lymph node staging. That's for sure. We know it. We know that thanks to our ultrastaging, we detect, twice as many patients who are lymph node positive. So then we can much better triage the management and triage the patients, and we know that if it's negative from ultrastaging, it's truly lymph node negative patient, and it's very, very reassuring.
I still agree with that. The only question is why to do the complete pelvic lymphadenectomy after the Sentinel if the Sentinel is so powerful in detecting everything? Just
yes, we already know the answer because we have the final data from the Centix, and we want to present them at ESMO in the fall of this year, and that Centical is also running. Of course, we have the evidence from the studies which perform both Sentinel and then lymphadenectomy. Argument can be that Sentinel is processed by ultrastaging, other lymph nodes just by one cut, so there can be some. So that's why we feel like we need some prospective evidence that if you really avoid full lymphadenectomy, that it's safe. that you don't have, twice as many pelvic recurrences in your patient.
Excellent. So thank you so much, David, for that. And now I'm sure this is going to be an easy question. Actually, Rene Pareja from Bolivia wants to ask this question himself.
David, thank you for releasing those interesting and very controversial guidelines. My first question is a comment, because there is no need to include TNM classification after FIGO 2018, because in 2018, another status was already put in the FIGO classifications. So I think I found it pretty redundant. But my main question is how to define experienced centers and high volume centers in order to define experts allowed to perform minimal invasive surgery less than 2 centimeters, because in Latin America, we have thousands of experts. Those experts have to be defined by themselves or defined by who? This is really tricky for understanding this part. Thank you so much, David.
Yeah, Rene, I have, of course, no answer to that, and you are right, and I can answer that there are, we also develop this quality criteria for surgical management of cervical cancer. So there are certain points, but in a real life, this is impossible. At the same time, Rene, it's in surgery in general. How to define, experienced surgeon in open surgery? It's very difficult, and to do some central quality assessment in surgery, it's impossible. So we can only rely on the volume, and then on the other, supportive criteria, but we don't have any objective ones.
So David, I want to jump now into another area where there's some questions coming about, and I think it's obviously relevant because, of course, cervical cancer is a disease of low and middle income countries, and we need to talk about the imaging because it's obviously very important. And for many patients, particularly patients with gross tumors, it's important to define whether the patient has parametrial involvement, whether the patient has vaginal involvement, or even lymph node involvement. So the guidelines talk about PET-CT and MRI and expert ultrasounds. Can someone like Rene in Colombia, or our team in Chile, Fernando Heredia, can they get expert ultrasound, PET-CT, MRI? What can you tell us about that?
Yeah, no, this is a very important question, and I find it, really, it's so controversial that the inventions which we introduced to the management of cervical cancer, like immunotherapy, ICG, robotic surgery, this is MRI-guided brachytherapy. These innovations are simply not available in the regions with the highest burden of that disease, and that's why I very much want to highlight here. We've just finished the analysis of the Centix data, and there was mandatory one of these two imaging methods, either MRI or ultrasound, not expert, ultrasound. And just by chance, we did not force anybody, but just by chance, it was 50-50. So 50% of institutions about used one or the other one. And then we analyzed carefully, missed parametrial involvement, tumor size measurement, and lymph node assessment. 3 important topics in the preoperative or pre-treatment assessment, local assessment of cervical cancer. These 2 methods were absolutely equal, the same. They were, and it is a picture of the real life.
Mhm.
So we have more and more data showing that ultrasound can be equally, because, you know, yes, MRI has some advantages, but ultrasound also. And ultrasound is a dynamic technique. So with the dynamic technique, for instance, to exclude parametrial involvement is much easier than with the MRI, because you can move with the cervix. You really see the slicing organs. So yes, definitely, I think ultrasound is the answer. And you know, what is expert ultrasound sonographist? Well, it's the guy who uses ultrasound heavily in gynae oncology. Well, they have some definition, but in general, definitely, you know, it's in our institution, you know, we have Daniela Fischerova, but we have many more. So definitely it's possible. It's like with everything, there is a learning curve.
Yeah.
But if you start with the ultrasound, it's you can still use in parallel another methods. And once you know, check that you have the same results, then you switch. So there is, you know, nothing dangerous for your patients.
Okay. Well, David, before we get back to our fellows for some questions, another point of controversy, I think, was the surgical staging of locally advanced cervical cancer. In the United States, we have data that is less than 5% of patients with locally advanced cervical cancer that actually undergo a laparoscopic periodic evaluation. We have the uterus 11 that was basically a negative study. So with such an unpopular procedure, with a prospective randomized study that shows no difference in outcomes, why do the guidelines suggest that surgical staging should still be considered?
Yeah, well, it's the wording of each recommendation is very important. If you do guidelines, you really fight for every word. So it can be considered, should be considered. It's a big difference. It's like it should be done or can be potentially done. So in the guidelines, periodic staging is simply can be considered. So it's, you know, we unfortunately the German study has one big limitation. They did not use PET scan. So you know, which I'm not saying, you know, not of course everywhere, but usually in high income countries, PET scan is a standard imaging technique for lymph node staging in locally advanced disease, and they did not implement it. So we still, you know, have this controversy. I can tell you that we do we lead a multi-center study now on imaging in cervical cancer. So we try to compare MRI, PET scan, and ultrasound for lymph node staging. It has never been done, so we use it mostly in locally advanced disease. It will continue for another a year, but I can tell you already that what we see quite often is false negative PET scan results. Even, you know, very obvious positive lymph nodes on PET scan are then finally enlarged lymph nodes, but negative histologically. So yes, I agree. You know, you said it's unpopular. In some European countries, it's very popular. It's done, like, you know, in the majority of cases, if the patients are suitable candidates for the surgery before chemoradiation, so it's done. So you know, yes, we have the prospective study, but unfortunately limited. And as you definitely know, there is a Parola study which has been already launched in France, which is a proper randomized prospective trial, including PET scan before the surgery, which will answer this controversial topic, finally.
Great. I again, before we go to the questions from the audience, I see Rene not only raising his hand, I think he's about to jump through the screen.
Yeah.
I think he has a follow-up question.
David, I think the uterus 11 result was skipped and was completely ignored, despite the classification was made by TAC, by CAT scan first. That's first. Second, PET-CT. 90% of deaths due to cervical cancer happens in low and middle income countries. 85 new cases every year in low and middle income countries. PET-CT is a very, very expensive resource. So it seems that those guides are designed for rich countries, and particularly rich countries don't have the number of cases of cervical cancer that we already have. And finally, having peri-aortic nodes, you are selecting the 3C1, so a high-risk population, 60% of overall survival at 5 years, in order to find the real 3C2, 38% of overall survival at 3 years. So why to pursue a systemic disease, a lady with peri-aortic nodes, to give a local regional treatment with extended field radiotherapy? I cannot understand. Can you explain me, please? Thank you.
Well, Rene, it is still a controversial topic. That's why it's not recommended. It's an option. Arguments, if you ask me for the arguments supporting this staging, it's of course mostly toxicity. So extended field radiotherapy, it's indeed a toxic treatment. Radiation oncologists already based on the Embrace study data, they push forward para-aortic extended field even for patients with 3 positive lymph nodes in the level 1 pelvis, so in the lower pelvis. Meaning that there will be a tendency to radiate more and more patients with extended field. But again, these are Embrace data are from very highly selected institutions with a fancy radiotherapy equipment. So their toxicity is properly not the same as many other institutions have, and so it's not a black and white situation, and I'm really awaiting the results, as much as the results from our study, because we will see, how MRI and PET scan and ultrasound will work for para-aortic region.
Great. So David, we'll go now to our fellow questions. I think Jen Davis Oliveira from UK is next. Nope, she may not be connected, so we can go to.
I think. Can you hear me?
Yes.
Hi, thank you so much. Such incredible work that you've done on this really, really useful for everybody. I just wanted to ask about patient involvement in the sort of development of this manuscript, and who was involved, how many people, and how did that work, and what did it bring to the work, as it's so important that we get patient involvement with the work we do. Thank you.
Yeah, Jen, this is very interesting question, actually. As far as I know, patients are always included as external reviewers in the process. ASGO uses, obviously, because ASGO has its own platform or a group of patients organization, which is called Engage. So So ESGO uses the contacts from Engage. I don't know the numbers, but I know for sure that some of the comments we received from the external review were also comments from patients. At the same time, I must admit that it's not an easy job for patients. And that's why ESGO started a few years ago the process of trying to have a bunch of patients who would be educated, let's say, who would receive some training in reading scientific literature, assessing, be involved in the process of the guidelines development, because it's we feel like it's an easy because we are involved, but for somebody from the lay world, it's quite a challenge.
Next question is Anisa Mburu from Kenya.
Thank you, Pedro, and thank you, David, for the great summary. My question is on what the paper mentioned about hypothermia. It was recommended as an alternative for weekly cisplatin. And I wondered, could you describe the conditions in which it's administered and its efficacy as a radiosensitizer? Particularly, how long should it be maintained and how soon should radiotherapy be administered after? Also, some centers recommend that gemcitabine be used in lieu of cisplatin. What's your experience or recommendation with this? Thank you.
Anisa, you are giving me a hard time.
I'm sorry.
No, it's okay. It's okay. No, it's okay. But I'm afraid, I'm unable to answer. It's rather for radiation oncologists. I know that it's there. It's in the guidelines as an alternative to cisplatin or to chemotherapy, hypothermia for chemoradiation. I've just arrived yesterday from the ASTRO Congress, which is the European Society for Radiation Oncology. And there was a lecture, like a state-of-the-art lecture on chemoradiation for locally advanced disease, and it was just summarized that the hyperthermia, is mentioned several, but there is no standard. There are no standards. There is nothing like internationally accepted standard for it. So, I don't think that we really have something like a recommendation in it. Okay. And I'm aware that even in the chapter on radiotherapy, there is nothing about it. You're right.
David, now a question from the audience, and I think, in the United States, it's exceedingly rare for anyone to give neoadjuvant chemotherapy for cervical cancer before surgery. But there's a question that comes up with regards to, is there any role anymore for neoadjuvant chemotherapy followed by radical surgery?
Yeah, well, this is one of the changes because in the previous guidelines, there was in the management of early stages of 1B1, 1B2, there was an alternative option, neoadjuvant followed by radical surgery, and this was deleted. This was withdrawn because after discussion, we summarized the recent literature, negative data, and we said that there is really no survival benefit. It has never been proved. So there is really it cannot be recommended as an option. And if you need an alternative to radical surgery, it's primary chemoradiation, which, again, according to EMBRACE data, which are prospective data, but prospective observational data, the survival of patients with these small tumors after primary chemoradiation is excellent.
Great.
Yeah. But there is one situation, and it's explored now by Neocon study, and this is the situation of fertility sparing of bigger tumors. Here we have an intention to really save a little bit of the stroma of the cervix, because our intention is not just to preserve the uterine body, but also part of the cervix. Without it, it will not be working. So it doesn't make sense to do fertility sparing. I saw some procedure where they cut completely the cervix, and then of course, it cannot work. So, so there, if the cranial extent of the tumor is higher, but it's a risky procedure, and in data which are available, there are deaths. There is more mortality.
Excellent. David, the next question is on Nuria Agusti from Barcelona.
Yeah, hello. Thank you, Dr. Cibula, for your work with these guidelines. Yeah, I will jump to another topic. And so my question is related to oligometastatic disease. So do we have well-defined cutoffs or surgical criteria for oligometastatic disease in cervical cancer, such as Tom-4 criteria in the lungs? Thank you.
Yeah. Well, this is another very nice topic, and very popular in oncology in general. I'm not aware of any criteria for cervical cancer specifically, but in my opinion, it doesn't matter whether the oligometastatic disease is related to the ovarian or cervical or endometrial cancer. It's rather important the organ or the location of this metastatic disease. So it's difficult to define it like the number of metastases or the size of the lesion or the region, because it's different. In cervix, it definitely differs whether you have liver disease or supraclavicular lymph node or a lung disease, but definitely it's a very important topic. We've published the analysis of the large data from the SCAN study, 20 institutions, more than 4,000 patients, and there were more than 500 recurrences. So we analyzed the survival after recurrences and interestingly, there were long-term survivors. So those who were 3 years after the treatment of the recurrence, free of disease. And among them, there were 5% of patients with distant disease, with oligometastatic distant disease, and they survived 3 years without it. So we should always think about a possibility of a curative treatment, and this oligometastatic disease really give us an opportunity for that. So no clear definition, depending on the organ or the location of the metastasis, can be different for different organs, and simply potentially treatable by local treatment, stereotactic thermal ablation surgery.
Great, thank you, David. And next is Teresa Pan from Austria.
Hello, and thank you, Dr. Cibula. My question was already half answered because it's already also about metastatic disease. And in case that we have a good response to systemic therapy in metastatic disease, are there some criteria to evaluate radical radiotherapy in the pelvis?
Yeah, thank you, and you are right that it's connected with the previous question, and what I said applies very much to this as well, that we should really during the treatment keep in mind this challenge for an opportunity to give to the patient or to offer to the patient a curative treatment. So even if there is a distant metastatic disease and we give a systemic treatment and we know that the chance is very tiny, small, but we see a very good response and there is still a residual local disease, we should consider local regional treatment. I don't think we will ever have a criteria for that. I would say it's definitely complete clinical response of distant disease, and then it's a general assessment of the patient. But it's going to be always individual decision.
Great. Next, we go to back to Italy. Andrea Rosati at Gemelli.
Hi. Thank you, Pedro. Thank you, Dr. Cibola. My question is about the fertility-sparing treatment. So it's specifically in case of negative margins and negative lymph nodes, but positive LVSI on the specimen, should we still counsel the patient for a fertility-sparing treatment?
Yeah. Well, there are certain criteria. The selection of patients for fertility sparing is the key issue, of course. Not to offer it outside of the reasonable risk, let's say. Of course, patient can think otherwise, and we probably see such cases in our clinical practice that you have a patient with big tumors and they still insist on fertility sparing. But in general, the good candidates are defined by tumor type, by the size of the tumor, but more specifically by the location of the tumor, which I mentioned previously. That if you have 1 centimeter tumor which is located endocervically, cranial close to the isthmus, then you cannot offer it because you will cut the whole cervix. But so it's rather the location and lymph node status. LVSI is a risk factor, but it's a risk factor specifically for lymph node involvement. So, if especially nowadays we use sentinel lymph node and sentinel lymph node autostaging, which is negative, then I don't think that LVSI is a factor which should lead us to avoid fertility sparing treatment.
Great. David, since we're on the subject of early stage disease and fertility, we'll go next to Ryan Kahn in New York City at Memorial Sloan Kettering. Ryan.
Hey, Dr. Cibola, how's it going? Thanks for the presentation. That was excellent. So another important challenge surrounding cervical cancer in women of childbearing age is the collaboration with our reproductive endocrinology and infertility colleagues. There's a recent article last week in JCO that touched on this, and one thing was abundantly clear, that even in cervical cancer, surprisingly low rates of both the referral for our patients to undergo assisted reproductive technology, as well as the uptake amongst our patients who do have the referral. So what do you see as barriers for why these rates are so low for our patients and ways to improve this for our patients in childbearing age?
Yeah, Ryan, thank you for that. It's really something what is a very which is the area of a need for the improvement, I think, because nobody of us have big numbers of these patients. So really put together a comprehensive center which will not focus only on the treatment, on the surgery, but who will really implement a reasonable follow-up and who will take care of the pregnancy and everything. It's not an easy job. We have just finished the analysis of, as far as I know, one of the largest series, retrospective, of course, series of fertility sparing treatment patients, more than 700 patients treated in Europe. It was a good study, so several European groups involved. And what was one of the interesting points was that only 50% of patients who were treated by fertility-sparing procedures really intended to become pregnant. So that's quite shocking. That's of course there is some risk associated with fertility sparing, and 50% only try to be pregnant. So so this is one aspect. Of course, it might be changing of the plans and everything. There are several aspects in it. But I absolutely agree with you that it's really must be a robust, comprehensive care, which is not finished by just cutting the cervix, but continues with the follow-up and the consultations at reproductive unit. But just one more sentence. Surprisingly, those other 50 and those who became pregnant, only about 20% were patients of who underwent IVF.
David, just a few more questions, because of course, obviously we can continue and there's so many questions, but obviously we want to be respectful of your time. And this question, I think, hasn't been addressed, and I think it pertains to surgery in the setting of recurrent disease. This question comes from Alexander Shuskevich in Ukraine. And he asked, can you please tell us your opinion about the role of pelvic exenteration today for recurrent cervical cancer? And I will add to that your thoughts on surgery for disease extending to the sidewall, because I saw that there was also a suggestion in the guidelines about consideration of the Lear procedure.
Yeah, so how to make it short? I would say, first of all, it's still irreplaceable. It's still irreplaceable because if you have really local recurrent in a patient who was treated for the primary treatment by chemoradiation, there is no other option with a curative opportunity. So if the patient is, of course, in a good status, if the disease is really localized disease, you should be able to offer this procedure. Of course, there are many aspects. It's very morbid procedure, quality of life and so on. I've been doing it for 25 years, so I've seen so many complications. It's a complex question, to see some patient who is free of cancer, who is treated successfully, but suffered from some severe complications and from chronic inflammatory disease in the pelvis. It's painful for us as for surgeons. At the same time, we should be able to offer it with the laterally extended or the disease which is attached to the pelvic sidewall. I think this is one of the really innovations or inventions which has been added to classical pelvic exenterations in recent 10 years. And of course, I don't plead for a Lear procedure if you have a massive infiltration of the pelvic sidewall. Such a case is a lost case. But I think that ability to go one step forward can very much help us to reach free margins. And those who do pelvic exenterations after pelvic radiation, that devil is in a detail, that you are in the middle of the surgery, you are in a situation that you see, fibrosis which is attached to the pelvic sidewall, and you don't know where is the border between the nerves and the bone and the fibrosis and the tumor. You don't have any methods to explore it. So the technique to say, okay, so let's go 1 centimeter beyond it, let's do resection of this muscle and little bit of bone and periost, and even I just did a resection of the sciatic nerve or half of it last week in one patient with recurrent cervical cancer. So those are tiny structures on the pelvic side wall, but definitely to know the anatomy in details and to be able to go one level beyond it can help you to do the exenteration with higher chance for the curative intent.
Great. And David, one last question, and I think this is reflective of several questions that were brought up, and this will go to Vansa Kosciavili between Europe and Asia in Georgia.
Hello, and thank you all. Which question do you recommend to ask Dr. Ramirez? Like, I had several.
No, you had a very good question, and I think is the question on surveillance and follow-up.
Okay.
Because
So Dr. Cibula, what follow-up approach you use for your patients? Like, there are several mentioned.
Yeah, Vansa, thank you very much. This is my favorite question. Do you have 30 minutes? No, I mean, this is one of the really also unmet needs, because we invest enormous amount of time and energy and money into the follow-up all the previous guidelines always says that we should see patient every 6 months, then every year, but this was one strategy fits to all. And obviously, there are so big differences in the risks of recurrences between 1A and 1B1, 1 centimeter, and locally advanced disease after chemoradiation. So it was always strange for me to see it that this is the recommendation. What ESGO guideline says, and I'm proud that we finally agreed on that follow-up strategy, and now I read it, I have it there, but the follow-up strategy should be individualized in terms of intensity, duration, and procedures, taking into account individual risk assessment. And let me now promote a little bit something from my institution, but we developed for patients after surgical treatment, based on this scan massive data, more than 4,000 patients, a model which we developed exactly with this in mind, to help to calculate, based on massive data, a probability of the recurrence at individual years after the surgery. This calculator is now available at ESGO website, and using traditional risk factors, you are using the data from this massive database, and you see individual risks, and then you can adjust according to your strategies and patients' possibilities, and so on, your strategy, and typically say, okay, look at this, you have such and such risk of the recurrence, so let's agree that we will follow you just for 2 years. We will see you once and you also have as the outcome of the calculator separately the risk for the local recurrence and for the distant recurrence. So I very much plea for individualized approach in the follow-up strategy.
Well, David, thank you so much. I think that we can all say that, of course, as expected, you did a fantastic job. Applause for you and your time. It's incredible to be firing away questions for an entire hour, and to have your expertise really is a joy and a pleasure and an honor for us. And I think that based on the number of unanswered questions, we can set up a booth in Istanbul where you have an actual bowl, and everybody could come in and place a tip, and therefore there will be a line, and and I will be very happy to be your agent for that booth.
Fantastic, fantastic, Pedro. No, thank you very much. You do really a fantastic job for the journal. Congratulations, Pedro. It was really a pleasure, and I see a lot of friends among the attendees. So it was really a very nice hour for me. Thank you very much.
Of course, thank you. And thanks to everyone who joined, and thank you for submitting your questions. And we hope to see you again next month for the lead article, where we're going to be talking about reasons for failed sentinel lymph node mapping and how can we potentially avoid failure of sentinel lymph node mapping. So we look forward to seeing you there. And for now, from Houston, from my new Methodist hospital and this amazing view, I say goodbye.
Thank you. Bye.
Take care.
Bye.
Bye.
Bye.